So final exam review. If you had attended on Friday, this is going to be a pretty similar session in terms of kind of the material covered and whatnot. And so generally what I do for these review sessions is I have these topics here. These are the topics that are going to be focused for 75% of the final exam is going to be all intensely focused on these topics 11 to 14. And I have these study questions that are found at the end of each of the sets of notes. And so what I've decided to do is basically take a look at these study questions. And usually what I do is I'm going to pick on a few, and then if there's any that are people are staring at and they're really, okay, I really want you to cover that one a bit more detail, I'll do that. So the ones I picked on last time on Friday, I think it took me about 45 minutes to cover. So I'm just going to do that unless there's something that people really are wanting to get in and talk about. Like I said, I think I picked about 2 from every topic here. So here's topic 11, for example. And here's topic 12. And so 12 is microbiomes, infections, and disease. Topic 13 was in 3 parts on the immune system. 2 and part 3. And then topic 14 was infections of the body. So like I said, I'm going to pick 1 or 2 from each of these and kind of go through them in a bit of detail. Some of the things I mentioned in class, I was going to cover a bit more. And so let's get into this, and feel free to ask questions. You can ask questions either by turning on your microphone, or you can always put things into the chat feature of Zoom, and I'll try to check the chat feature regularly in case there's any questions regarding that. So here's the first one. Just a nice, easy one to get into. Topic 11 was on disease transmission, epidemiology, and just talking about nosocomial infections. So if you remember what a nosocomial infection is, it basically means hospital or healthcare acquired infection. So sometimes that age traditionally used to be hospital acquired, but we're kind of starting to say healthcare acquired because, of course, there's lots of situations that may not be hospitals that sort of fall into this category. So you see this acronym here a lot out there in terms of people talking about these nosocomial infections. I don't know why there's a special word, but it is English. In English, we have lots of extra words for things. It's kind of just the way we do things, I guess. So if you remember, we did talk about this in lecture. This is the slide that kind of featured factors that contribute to these kind of infections. And so you can see I just have some extra notes about this, right? You're going to have pathogens in the hospital because sick people are going to the hospital. And of course, the biggest concern is these superbugs. MRSA, for example, is a big one. Patients with compromised immune systems. So I'm sure we could make a big long list of what those situations might be. People may be there because they have pneumonia, or they may be in intensive care because they're old or newborn, premature, those kind of things. Organ transplants, diabetes. There's all sorts of things that may compromise somebody's immune system. Other patient, staff, medical equipment, lots of studies on this kind of thing. It's really hard to say who are the biggest perpetrators. It's very hard and difficult sometimes to control visitors, for example, and trying to get everyone to wash their hands and those kind of things. Different hospitals have different success rates about those kind of things. Sometimes the staff is the problem, just in terms of having not good enough hospital policies and things like that. And then number 4, invasive procedures, of which there's a bunch, but catheters is number 1 and surgery is number 2 in terms of invasive procedures that can introduce a pathogen to somebody's body systems. Okay, so that was an easy one, I'm hoping. just remembering kind of what those four things are is obviously helpful. What are the four sources of pathogens? So this was one of the study questions, and I had a couple of people ask about the sources of pathogens. Another word for sources is reservoir. Okay, so let's take a look at the four categories. Number one was normal flora. And so this means organisms that are already living with you can be a potential source of that infection. Lots of examples there. For example, E. coli is a good one. E. coli, which is normally found in the intestine, can sometimes cause bladder infections. Another example is Candida. Candida, so that is, of course, yeast that can cause yeast infections. So when somebody takes antibiotics, it can kill a lot of the bacteria in the body and allow the yeast to basically thrive. Number two, human carriers. I'm not going to write down some examples of those. Those are the most common types. You can think about all your sexually transmitted infections. You can think about lots of respiratory infections such as the cold, COVID, influenza, those kind of things. The list goes on and on. And like I said, that's usually the easiest category for people to know examples for. Animals, so zoonotic infections, so that would include things like rabies, West Nile virus, Lyme disease, plague, bird flu. So there's a big list of those potential infections. And then abiotic. There's really two or three examples of those that are good ones that are covered in this course. Two of them are related. We have botulism, and I'll talk about that a little bit more. And the related one is tetanus. And those organisms are basically found in the soil. And so they're not coming from any of those other sources. They're soil organisms that can cause infections, right? And so they kind of have their own category. There's other examples. Cholera is another one, not really relevant to Canada. Some people might put anthrax in that category. I'd more or less put anthrax as that comes from animals, but you can get it from soil because the endospores can hide out in the soil. But normally it's living in animals. So botulism and tetanus, they do live in the soil and can cause human infections. Okay, so let's get into some of the more difficult stuff, things that you may not remember us talking about. And one of the ones I want to talk about was a little bit about Legionella and other waterborne infections. And sorry, I'm just gonna grab a glass of water for a second. 1 second here. I got it right here with me. Feel tickle on my throat. Okay, so what was I gonna say here about Legionella? So Legionella, other waterborne infections. So I think I had three categories as I talk about. So we'll call this causes. And number two is transmission. And then the third category is symptoms. So you can see legionellosis is caused by Legionella. There's a couple of different species. Pneumophila is kind of the most common one. And maybe you can see from that diagram that it's a lung infection. So we'll come back to that in a minute. Other waterborne infections, a huge list. So let's just list some of them. We had, of course, different types of E. coli. We had hepatitis A. What else we have? Norovirus, Salmonella, Giardia. That's just a few off the top of my head. I'm just trying to think of what else we talked about this semester. We talked about Entamoeba. There's other organisms that we didn't really cover in any detail, like Campylobacter, and you could throw polio in as a waterborne infection. And so usually the case in most waterborne infections is obviously water, but we're talking about fecally contaminated water. So we can put that down as our transmission route. So fecally contaminated water, or food, I guess, really the same idea. So we'll put that water / food. And most waterborne infections, it's the typical symptoms of diarrhea and vomiting. So diarrhea, vomiting, and any related symptoms to diarrhea and vomiting. So, intestinal cramps and those kind of things. And you could throw in fever for some of these and whatnot, but those are kind of the typical symptoms, diarrhea and vomiting. So Legionella is unique. It's sometimes considered the #1 waterborne infection in Canada, although it's kind of not necessarily fitting into the same category as these other diseases because it is spread by mist. So Legionella is an environmental organism, and it can live anywhere where there's warm water. And kind of the #1 area in Canada is hot tubs that haven't been treated or cleaned properly. So I'll just put that down, mists. And there's other scenarios. I don't really know a lot about air conditioners, but apparently large buildings have cooling towers for their air conditioners on the rooftops. And I don't really know exactly how these things work, but I guess they can create mists if they're not cleaned properly annually or something like that. And every once in a while there's an outbreak. And unfortunately, it's not just people in the building. It's actually spreads, throughout the, it could be a whole block where there's suddenly a handful of Legionella cases because people walking by are getting exposed to the mist created by these cooling towers that I don't really, like I said, don't really understand the engineering behind that kind of thing. So symptoms are going to be respiratory, and we'll call them pneumonia type symptoms. So pneumonia-like symptoms. Also, usually there's a fever in there as well. And which is pretty common with bacterial pneumonia, people having a fever. I'm not sure why that is, but that seems to be the case. So you can see very, very different. In fact, sometimes Legionella is called Pontiac fever for some reason. I don't know what the relationship has to do with the automobile, but just another little tidbit for you. Okay, so like I said, getting into some more niche stuff, and like I said, there's some comparisons and some other things I want to do. Just picking on some of these questions here. All right, next one. It says compare West Nile fever and Lyme disease. All right, so what I've done is I've started making a table here to compare these two things. And why these two things? These are the #1 and #2 vector-borne diseases in Canada. So we talked a lot about vector-borne diseases. There was African sleeping sickness, malaria, Chagas disease, and so on. But a lot of these things are not common in Canada, whereas these two here actually are. So let's take a look at these. So Lyme disease, the cause. The cause is a bacterium. Write that down, bacterium. And the bacterium is called Borrelia. I have to just check the spelling on this. This is something I always misspell. Borrelia burgdorferi. And I'm going to spill out into the other side of the table because it's a long word. I know spelling is funny. It's something I used to be able to do. I don't know what happened the last few years. I used to be able to spell things in 2018, but I don't know. The brain's just doing weird flippy things. So what I'll do Lyme disease first. We'll come back to West Nile. Okay. So we have a bacterium, and this is actually a spirochete. So I'll draw you a little picture of spirochete, which is kind of a spiral shaped. Maybe it's not so twisty. Maybe it's more like this. Organism, and it's technically a gram-negative, and it has one of those endoflagella, so it can corkscrew and travel through tissues that way. So the reservoir of Lyme disease is actually the white-footed mouse. White-footed mouse. Some people will talk about the deer. The deer are a little bit more important for the tick life cycle, but the bacterium, the natural reservoir where the bacterium lives, is actually in the mice. The deer, it's a small percentage, like 5 to 10%. Like I said, it's kind of they're helpful for the ticks to survive. And in fact, the white-footed mouse and the white-tailed deer tend to have very similar habitats in terms of climate, and they're both well habituated to kind of living near humans, and in areas where you might live in a suburb and there's a nice forest and trails nearby, and that's kind of where those types of animals like to live. They're not as afraid of humans as a lot of other wildlife. So transmission, of course, is the tick, and the tick is called the black-footed tick, or sorry, black-legged tick. Getting mixed up with the mouse. Sometimes it's also called the deer tick. I would accept that as well. There are other names that I've heard that are maybe a bit more geographical in terms of nation. I think in some places in the States, it's called the bear tick. Never heard that in Canada. I've also heard Lyme tick once or twice, but black-legged tick is the most common. There's actually two species. There's the western black-legged tick, which lives west of the Rockies. Not too important to distinguish between the two of those. Scientific name, also not so important. Just know that it's a tick. Symptoms. Lyme disease is one of those things that can have potentially a lot of symptoms, but there's two that are worth mentioning. One is the bullseye rash. Bullseye rash. And that's we think it's about 80% of cases. Some people debate it might be a little bit less, but that's kind of the most common thing and the most distinct thing, because there's nothing else like it that quite gives that rash, except for another tick-borne disease that doesn't happen anywhere in Canada. So it is very, very distinct. The other one is, we'll call it arthritis-like symptoms, we'll say. Arthritis-like symptoms. And so what do I mean by that? Aches in the joints and things like that. And like I said, there's a whole bunch of other symptoms that could go along with Lyme disease, particularly people who are left untreated. When you get into the longer term stuff, you can talk about all sorts of things like Bell's palsy, brain fog, chronic fatigue, those kind of things. But in terms of kind of the main symptoms, those are the two big ones that show up in a lot of cases and are worth mentioning. So treatment. We're treating a bacterium, and so with that, we can use antibiotics. And by antibiotics, I mean antibacterial drugs. There's a few of them out there. I think the most common one now is a doxycycline, which is a type of tetracycline. But if there's resistance or something like that, sometimes they mix it up a little bit. And sometimes we're also looking at treating the symptoms, particularly people who have some longer term symptoms. That's the case. Usually the bacteria is actually cleared, and now they're trying to treat the symptoms, which I'm not going to get into a ton of detail, but long-term kind of symptoms of Lyme disease can be pretty bad, and has affected a number of Canadian celebrities. Justin Bieber, Shania Twain, Avril Lavigne. There's a few there that have suffered with symptoms of Lyme disease and took a couple of years off their career, each of them, just to try to deal with it. Okay, so Lyme disease. And then the other one is West Nile fever. Okay, so West Nile fever is caused by a virus. Okay, so it's called West Nile virus. Sometimes people actually call the disease West Nile virus, but technically the disease is usually called West Nile fever. So sometimes you'll see abbreviations like that, and it's a virus, so I'll just represent it by some little tiny specks like that. So the reservoir for West Nile fever is birds, and many types of birds. Many types of birds can be the reservoir. Robins, so if you know what a robin is, it's those, they have the red breast on them. I think it's actually the technical name is the American robin, but they're found all over Canada. In fact, I've seen them in Fort McMurray, and that's the reservoir for West Nile fever. Transmission is mosquitoes, specifically mosquitoes called the Culex mosquitoes. And there's actually two main species in Canada. There's kind of a western version and an eastern version. The eastern version, common name, I think is like the house mosquito or something like that. But it's just good enough to know mosquito. You don't need to know Culex for this course. They tend to be found in a little bit more warmer areas in Canada. So we're talking about in Alberta, we're looking at Lethbridge, Medicine Hat kind of area, and not so common as the weather gets a little cooler. So that's good for us up here up north. Symptoms of West Nile fever. So in this case, we're looking at flu-like symptoms. So flu-like symptoms. And what do we mean by flu-like? So obviously if it's called West Nile fever, aches, headaches, chills, those kind of things. And in some cases, the thing that can actually be fatal is encephalitis. So that one is worth mentioning. So encephalitis, by the way, if you don't recall, is swelling of the brain, and it can be fatal. And particularly, it's more and more fatal the older you get, and old people are quite susceptible to this. So this is the kind of thing that is rarely fatal nowadays because if there is a suspected case of West Nile, we can treat that now and kind of head it off at the pass. So in places like Lethbridge, the physicians are a little bit more aware of, okay, it's summer and we don't usually get the flu in the summer. And so, there's more of a chance that they're recognizing that it could be West Nile and they're going to test for it and treat someone for encephalitis. Treatment is basically treat the symptoms. This is a virus. There's no antiviral against West Nile virus that I know of. And so we're looking at treating the symptoms. So that usually means you go home and you go to bed and you get fluids, you take Tylenol, things like that, unless there's suspected encephalitis. And then in that case, they're going to give someone some sort of steroids to kind of cool down the immune system and prevent the encephalitis from being fatal. Okay, so Lyme disease and West Nile. Moving on. Like I said, if you have any questions, feel free to drop them in the chat box. I'll get them to them eventually. This is another one that's come up a few times. It's actually, it looks complicated, but it's just one that requires just a teeny tiny bit of kind of critical thinking in terms of what is going on here. So what is going on here? This is the classic case of basically of an opportunistic infection, right? So an opportunistic infection is basically where an organism is in a situation that where it previously was not able to cause disease, and now it's in a situation where it can cause disease. And in lecture, I think I broke it into 4 categories. The textbook I know has a list, and I think there's about 15 scenarios, but I like to organize things into categories. Here's some examples, right? Where someone may get an opportunistic infection, right? A host with a weakened immune system. So someone with HIV, they're now susceptible to all sorts of weird diseases and fungal lung infections that normal people just don't get. An altered microbiota. So disrupted gut microbiota, for example, we talked about antibiotic-induced diarrhea. So somebody takes some antibiotics and now that gives a chance for Clostridium difficile to grow and propagate and then cause some troubles in the gut. Breached integumentary barriers. So now we're talking about an organism that's found in one place and gets introduced to a new anatomical site. And that's really what we're talking about here with this E. coli infection, right? We have an intestinal puncture, and so now E. coli is getting exposed probably to the blood. And of course, that is, going from a normal benign situation to the organism now is causing a lot of trouble. And then other complications. So there's a huge long list of things. People have diabetes or cystic fibrosis, or all of these complications sometimes make people just more susceptible to certain types of infections that than normal healthy people would not be able to get. So like I said, this one here, it is just really talking about that. It's throwing a scenario down, which is an opportunistic infection, and asking you to explain it. And I'm just bolding that to say, hey, this is the answer to that question. So let's talk a little bit about E. coli. We talked a lot about E. coli all semester. And what I want to do is kind of just say, okay, here's some of the essentials, right? So you don't get bogged down in all the crazy amount of details. First thing to know is that E. coli is the number one cause of bladder infections. And usually we call these ones UPEC. So UPEC, it stands for uropathogenic E. coli. I don't care that you know that acronym, but you should know that something like 80–90% of bladder infections are caused by E. coli. And the other thing to know about that is that it's not all E. coli that can do that. It's only certain strains that have this thing called a P. pili. They have this special, they have a gene for that, and sometimes that's found on a plasmid, and it allows them to attach them to those tissues. What else to know? Most other pathogenic E. coli fall into the traveler's diarrhea category, and these ones are actually called ETEC. So ETEC stands for enterotoxigenic E. coli, and these ones are spread by human fecal matter. And so that's why it's called traveler's diarrhea, because in Canada, we have very good sanitation systems in most parts of the country. And so most of us are not getting exposed to getting E. coli in our drinking water, quite honestly. Other parts of the world are not so fortunate. And sometimes that involves basically sewage being dumped into rivers and oceans. And then of course that gets into drinking water and causes traveler's diarrhea. So that is, again, another particular pathogenic E. coli that most of us don't have in our gut. The other one to know is E. coli 0157. So if you want to know one strain, remember this one here, 0157. That's an O, not a 0. And this one is not coming from human fecal contamination of water, but this was the one that comes from cow manure. And this is the one that we see in the news all the time. Anytime you see E. coli in the news, 90% of the time they're talking about 0157. So it's like, let's say it's an asparagus recall or a romaine lettuce recall. And in many of those cases, what has happened is you've got a farm with cows, and then it's next to a farm with asparagus. And sometimes there's excessive rainfall, and that leads to the manure from the cow farm kind of washing over into the asparagus, and the asparagus gets picked and sent out to people. And so, that's one of the kind of the typical scenarios where this kind of thing might happen. Sometimes it's associated with hamburger meat, undercooked hamburger meat, and things like that, because of course hamburger meat comes from cows, and so it's always a possibility that contamination is there. What else to know about E. coli? These ones here are pathogenic because they have virulence factors. They have extra genes that allow them to do what they're doing. So in the case of the ones that are causing disease of the gut, they often have enterotoxins. So entero, remember entero means gut. So there's entero. And they have some sort of toxin that's causing diarrhea. It could be normal diarrhea, it could be bloody diarrhea. And that's kind of how the classifications come down with these organisms in terms of which toxins and virulence factors they come in. And so there's that chart of all the different types of E. coli. And like I said, it really is just kind of classifying them based on the toxins and things like that they have, because it does lead to, differences in the clinical manifestations of the diseases. One other thing to know about E. coli is it is pretty good at growing in a lot of places. And so it can be a cause of all sorts of other opportunistic infections. So when we went through topic 14, you may have noticed E. coli just kept popping up again and again and again, right? It can be cause of blood infections, bacteremia. It can be a cause of pneumonia. It can be a cause of meningitis. It's not the usual cause of any of those things. I'm not sure what percentage, 1% or less than 1% or something like that, but it is a cause, because sometimes it does get into the wrong place. Partly because, E. coli is everywhere. fecal matter is everywhere because we're dealing with it as humans, and E. coli can survive for a certain amount of time in the environment outside of the intestine, and so it can have a chance to get to those other body systems, particularly in hospitals. So somebody's saying, is E. coli 157 referred to as EHEC? Yes, thank you for that. So like I said, I care less about these acronyms than kind of some of these points, but EHEC stands for enterohemorrhagic E. coli. So hemorrhagic means you're bleeding internally. And so we're talking about a bloody diarrhea. This is the one too that can be particularly dangerous for elderly people. And if it gets into the kidney or the blood system, it can be fatal in some cases. Okay, so that was pathogenic E. coli. So like I said, there's a lot of information, but there's kind of 5 points that are some of the most essential information about E. coli. If you look at the pathogenic types, you've got urinary tract infections, you've got traveler's diarrhea, and then you've got the bloody diarrhea from the cow manure, E. coli 157. Point 4, they're pathogenic because they have extra toxins and things like that. And number 5, coli can cause other infections if it gets into the wrong place. And it may not be the most common cause, but it can do so. So more on topic 12, just kind of want to review some of these toxins. Sometimes people get these mixed up a little bit. Don't need to worry too much about cholera toxin, but I know that was in the study question, so I'll just review that one as well. So one thing to know is that these are different organisms. So we can write down the organism names. So organism botulism is a Clostridium, and it's botulinum. Botulinum. Gotta sound that out in my head here. And tetanus is another Clostridium. And it's Clostridium tetani, like that. So these two are soil organisms. So, and they form endospores. So I'm going to just represent them like this as rod-shaped cells, and you can see there's the endospores forming. So there's some for Clostridium. Tetanus sometimes it looks a little bit more like tennis rackets. So maybe I can draw one like this. Sometimes a little bit like that. I don't know how to draw a tennis racket. All right, so I'm a terrible artist. Anyway, we'll just scratch those two out. They're kind of not looking appropriate. Anyway, so they're endospore forming organisms. They're found in the soil. Botulism and tetanus, right? Botulism, remember, is the same toxin that causes that is used as Botox. So that causes paralysis. So in the case of Botox, we're basically trying to paralyze muscles and local parts of the body, such as the face, for either therapeutic or cosmetic. And if somebody eats contaminated food, it can get all over the body and cause death, right? So that's obviously not very good. Tetanus is kind of the opposite. So sometimes tetanus is called lockjaw. So you can imagine you're talking about, rather than paralyzing the muscles, you're not allowing them to contract. So I'll just call this a muscle lock. I don't know how else to describe it without a big long sentence, but like I said, preventing contraction of the muscles. So 2 different toxins. Like I said, just kind of wanted to, people tend to get them mixed up a little bit. Cholera, just to finish off this one here, I won't ask you about cholera on the test. It is kind of your classic example of a vibrio, which is a bent rod. So they kind of look like this. And they're gram-negative, by the way, and botulism and tetanus are gram-positive. Cholera can be found in water, also human fecal matter in some parts of the world. And this causes diarrhea. very, 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 very profuse diarrhea. Some people can get dehydrated and die from cholera within 24 hours. The treatment is usually actually just rehydration, and rehydration with lots of salts, because you're not just losing water, but you're losing electrolytes as well. So I see there's a question here. Somebody's asking, do botulism and tetanus have different types of toxins? All of these, botulism, tetanus, and cholera, would be considered exotoxins, meaning that the toxins are secreted by the organism and are causing the disease. Remember, endotoxins are part of the organism, and usually when we talk about endotoxin, we're talking about part of the membrane in gram-negative organisms. All right, topic 13 on the body's defenses. And so what I want to do is spend a little bit of time comparing the two types of immunity, adaptive immunity, humoral and cell-mediated immunity. This one here, I've typed it all up, just lots to cram in there. And if I'm going too fast, don't worry, I'm recording this and you can always review the recording later. And so, like I said, I kind of want to just compare these things in different aspects of what's going on with these two systems, right? So, humoral immunity, if you recall, is the part of the immune system that is dealing with B lymphocytes. So, humoral means blood or fluid or something like that. So the immune response isn't just in the blood; it's often in the lymph. But humoral is an old word for blood. So these are also called B cells, by the way. And just getting ahead of myself here. And the T lymphocytes are called T cells. Lymphocytes, so lymph means lymphatic system or lymph fluid. Cyte means cell. So it's just a little bit more specific than calling B cells. So where do they get their names? B cells is not blood, but B for bone marrow. And T is for thymus. So when we say mature, by the way, when we say mature, we're talking about a process called clonal deletion. And this is where the body eliminates cells. Body eliminates. Okay, I can't spell. I told you I couldn't spell today. Let's try that again. Body eliminates self-reactive cells. Sometimes thinking and doing and talking, that's a lot of things to do at once. So self-reactive cells. So that's what's going on there when we say mature, right? Your body makes all sorts of huge variety of B cells and T cells, and part of that maturation process is this thing called clonal deletion. Like I said, it's kind of just the body trying to remove cells that might react to the human body. And obviously, if that doesn't work right, you can lead to autoimmune diseases. All right, so what's the next one? Type of pathogen or foreign substances recognized. Okay, so this is where they start to differ quite a bit. So the B cells are secreting antibodies. And these antibodies are binding to things I'm going to call free circulating microbes or particles, because they don't necessarily react to just microbes or pathogens. So what does this include? Viruses, bacteria, small foreign cells, so we can think of things like yeast and whatnot, and quite a few different types of molecules. So protein toxins, it's our B cell, our humoral immunity that actually reacts against the tetanus and diphtheria toxins, and is completely part of the humoral immunity, and no T cells required. So anything that can really get destroyed by phagocytosis, and we'll talk about that in a couple of minutes here. So the cell-mediated immunity are basically other things. So usually this means larger things containing antigens and larger cells for the most part. So what does this include? Large parasites, doesn't have to be necessarily parasitic worms. There are some protists that are large, and there's always overlapping reactions between these parts of the immune system, and that they're a little bit redundant in that one organism can get attacked by the humoral immunity and the cell immunity in terms of the overlap. What other large things? Virus-infected cells. So viruses themselves are quite tiny and can get destroyed by the humoral response, but in many cases they're actually found in very, very small numbers, and the body doesn't actually detect them until they start infecting the human cells. And the human cells will start to produce viral glycoproteins, and this is what's recognized by the T cells, and it's going to destroy those cells. And the other big one is tumors. Sometimes we have abnormal cells in our body. In fact, it happens on a daily basis, and our immune system recognizes these abnormal cells and destroys them. There are other things we could throw in there that are reacted by the cell-mediated response, such as transplant tissues and things like that. But the first three are kind of, the ones to really focus on here. All right, what is next? What happens when the cells are activated? So that's a good question, because how does the activation kill what we're trying to kill, right? So how's the pathogen killed, and how's the immune system remember the pathogen? So what happens when B cells are activated? B cells secrete antibodies, and they make memory cells. Okay, so we'll talk about those antibodies in a minute. In fact, I have a little bit on the next slide that addresses antibodies. What about the cell-mediated response? I guess we'll get to that in a second. How's the pathogen killed? B cells secrete the antibodies. This should say secrete antibodies against the pathogen, and this usually leads to phagocytosis, although there are other things that might happen. And like I said, I actually have a whole slide on this next, so I'll come back to that in a minute. And then how does the immune system remember? We've already mentioned that. We've got these long-lived memory cells. Memory cells in some cases can live up to like 50 or 70 years apparently, which is just really, really remarkable. So what about cell-mediated immunity? Okay, so T cells this time become activated and they become cytotoxic, and they make long-lived cells. How is the pathogen killed? So cytotoxic means that they are able to kill other cells, and there are a few mechanisms that describe what this is like. I kind of class, I called it the kiss of death. And like I said, there's different ways they can do this. They can secrete toxins, which punch holes into the pathogen. If it's a tumor cell, they can induce something called apoptosis, which is basically telling that cell to kill itself, commit suicide, and lots of different mechanisms I'm not going to get into. Just know that cytotoxic means they bind it, and it somehow leads to the death of that target cell. And then same answer down below, we're making memory cells, and those memory cells are going to hopefully remember the pathogen for the next exposure. So that's kind of the comparison here. We can get into a lot more details on these things, but this is what I want you to really focus on remembering. Like in terms of how these things are done, there's lots of overlapping concepts between the two different types of immunity, and there's different scenarios that could happen. Sometimes you're involving dendritic cells and activator cells and those kind of things. I don't want to get bogged down into all of those details. So let's just talk about antibodies here, and just bring you back to basically this slide here, where we had what happens when an antibody binds an antigen. So the classic scenario is opsonization, and opsonization basically means something is labeled, and that leads to phagocytosis. So it's just a fancy word for saying that phagocytosis will happen to this thing, or is it inducing phagocytosis? Sometimes the antibodies recruit what we call our natural killer cells. These are a type of T cells that can do that cytotoxic killing. So sometimes that's a scenario. We talked very, very briefly about the complement system, and the complement system often is inducing other parts of the immune system. So I'm not going to get into that right now. The other two categories, agglutination and neutralization. So agglutination is clumping, and that often enhances or leads to phagocytosis. And in the case of toxins, if you have an immunity against, like I said, tetanus toxin, the antibodies can actually neutralize it, meaning binding the toxin, preventing the toxin from doing its nasty business. And that will often enhance and lead to phagocytosis. So you can see with antibodies, really it's leading to one of two scenarios. In most cases, we're talking about phagocytosis. In some cases, we're talking about cytotoxic killing of some sort. Okay, so I know I have a few more here to cover. Just a time check. So I think we're doing okay for time. You guys can have me till 12 o'clock today if you want. So lots of time to talk about a few things if you wish. So next question, it says talk about, describe the 6 types of vaccines. So what I want you to know with these types of vaccines is kind of a basic definition of what it is. And it's useful to know a couple of examples of each. So why don't we go through these? So attenuated is kind of a fancy word that means weakened. So somehow, through several mechanisms, there's genetic engineering and breeding and things like that, we can make weakened pathogens. Usually we're talking about viruses in this case. And like I said, there's more modern ways that you can do this kind of thing. And there's a whole bunch of examples. And this is actually one of the oldest mechanisms and done by quite a few manufacturers. So the classic example is the MMVR vaccine. So that stands for mumps, measles, varicella, rubella. So mumps, measles, varicella is the one that causes chickenpox. Rubella is the German measles, right? So those are all attenuated viruses all in one vaccine. The other one is the flu mist. So flu mist, it might be a capital M, I'm not sure. That's a trademark. That's the nasal flu vaccine that I haven't seen in a couple of years. The one they stick up the nose, and that is an attenuated virus. Many more examples. Another one is the oral polio vaccine. OPV is oral polio vaccine. And that's just worth mentioning because we talked about polio for a little bit. So inactivated is just another word for killed, right? And sometimes we don't say killed because a lot of people don't consider viruses to be alive anyway. So inactivated is maybe a bit more accurate in some ways. So there's ways to kill them. Usually the classic killing of these things is using formaldehyde or something like that. Examples would be the flu shot. So this is the one that you're getting in your arm, and this is a killed version of the flu virus. And like I said, it's chemically deactivated, and then it's part of the vaccine. The other one is the injectable polio vaccine as well, and that's also a killed viral vaccine. Conjugate subunit. I'm not going to get into the differences between what a conjugate and a subunit is, but it's kind of there in the definition. You're looking at basically a part of the cell that is the vaccine. So you're not even getting the pathogen at all. And for example, the examples I think I gave in class, I gave a few examples, but you've got the pneumonia vaccines, and those are carbohydrates. There we go. So those are carbohydrates that are found on the capsule of the organism. And there's a few different formulations. I think I mentioned there's Pneumovax 19, Pneumovax 23, and things like that. So that means it has 23 antigens in it. Other ones, we've got the hepatitis A vaccine and the, what's the other one I'm thinking of? The meningitis vaccine. So meningitis. Okay, just looking at my spelling again. So there's a whole bunch. A lot of the newer vaccines fall into this category, partly due to some new technologies and just new ways to produce those molecules from the bacteria that have kind of come out in the last 20 to 30 years kind of thing. So a toxoid is an inactivated toxin. So in this case, we've got the tetanus toxin, the diphtheria toxin, to check that spelling. If I check or spelled diphtheria right, I feel like I'm missing a letter or something like that. There's also acellular pertussis. I'm not actually aware of any other examples other than those three. So inactivated toxin. So you're having an immune response against the actual toxin. And that's how it works. So not the organism again. And the last two are the new ones, and the only examples are from COVID-19. Nucleic acid, in theory, could be RNA or DNA, but there aren't any DNA examples, at least for humans. So these are messenger RNA vaccines. So usually it's a messenger RNA, and the messenger RNA is coding for some sort of viral component. So in the case of COVID, it's coding for the spike protein. Usually the messenger RNA is coded in a lipid that helps deliver to the cell, and that's how they work. So mRNA codes for spike protein. So this gets your own cells to make the spike protein, and then your body recognizes that as a foreign molecule and is going to mount an immune response against it. There are some people that actually worked at trying to make conjugate subunit vaccines with the spike protein. Those ones just haven't been approved in Canada. I don't know what the situation is with those ones. So this includes the Pfizer, I spell Pfizer right, and the Moderna vaccines. Both of them have new names for the vaccines. What's the one? Comirnaty and Spikevax, which no one's calling them that. Everyone's calling them Pfizer and Moderna, but you're welcome to learn both names if you want. Viral vector. So this is where you have genetic instructions. So, and again, for the spike protein, and it's going to be delivered by a harmless virus. So in the case of AstraZeneca, for example, they're actually using a chimpanzee adenovirus that causes like a cold in chimpanzees. This virus is good enough to infect a human cell, deliver that DNA, and that's about it. And why is this key? Because it's a DNA vaccine, so it's really hard to get DNA to a nucleus, and that's where the DNA needs to get. And it's the same idea as the nucleic acid vaccines, is it's coding for a spike protein. And in Canada, this would be AstraZeneca. I think also has a new name, and the Johnson & Johnson or Janssen. I don't know if there's two N's in Janssen vaccines, and I don't actually know anybody who's had the Janssen vaccine. It's just been a little less common in Canada. It was sort of the latecomer to the whole party. The advantage of that one, though, is that it's a one-dose vaccine. Okay, so like I said, know some examples of each of these. Examples are always good for my tests. Okay, so a couple more things. Two types of immunodeficiencies. So what I want you to do is not think of immunodeficiency as hypersensitivities. Hypersensitivities. These are two different things, okay? Immunodeficiency is where the immune system is not functioning properly. It's deficient, right? And we talked about two types. So one was primary. This is something that you're born with. And there are many types that don't really usually go detected because of the redundancies in the immune system. But kind of the big one we talked about was the bubble boy syndrome, which is also called SCID, which is, I think, severe combined immunodeficiency. The other is acquired, meaning you get it somewhere later on in life. And this could be due to things like malnourishment. This could be due to organ transplants. So you're on immunosuppressants. Or this could be because you get measles or because you get HIV. So measles can knock out, actually kills memory cells. So that's bad. HIV kills T cells, CD4 cells, and can destroy the immune system entirely. So two types of immunodeficiencies, right? Primary and acquired. Like I said, a variety of causes for acquired immunodeficiencies. Hypersensitivities On the other hand, there were 4 categories. I kind of broke them really into 2 categories. We had allergic diseases. And allergic diseases, that includes a whole bunch of things like hay fever, asthma, anaphylactic shock, eczema, those kind of things are allergic diseases. And the other ones are the autoimmune diseases. Autoimmune diseases. Really apologize for my handwriting. It's not easy writing on a computer screen. For some reason, it's kind of awkward. So what does this include? Autoimmune diseases. A whole bunch. Type 1 diabetes, lupus, farmer's lung, hemolytic rejection of the newborn, Crohn's disease. There's a whole bunch. You take a look at the lecture notes. Like I said, there's lots of examples there. Okay, so let's talk a little bit about AIDS, and just kind of wanted to review some of the symptoms and the clinical diagnosis there. So if you take a look at this first section here, this is the acute phase of AIDS and HIV infection. And people end up with usually a mono-like illness. You can see the symptoms are down here, things like a fever and swollen lymph nodes, sore throat, those kind of things. And usually goes away because the body can mount an immune response against this virus. But what you do see here is in this asymptomatic phase, the number of CD4 cells are slowly getting killed off. And that takes quite a bit of time, a number of years, 8 to 9 years kind of is typical. This is obviously all without treatment. And then when we get over to here in this last phase, so the immune system is just getting totally destroyed. And we have kind of 2 phases here. Clinical AIDS is the last phase, and you can see it's defined specifically by how many CD4 cells are in there. And there's a number of diseases that are kind of characteristic of it. I'll get to that in a second. Before that, though, is something that's called AIDS-related disease or complex. And this, we're talking about just more opportunistic infections than usual. And maybe not quite as serious as when somebody gets to clinical AIDS. In terms of clinical AIDS, what diseases are we talking about? So we talked about disseminated shingles. So by disseminated, I mean all over the body. Same thing with herpes. You can have rashes all over the body from disseminated herpes. Different types of sarcomas. So what is a sarcoma? A sarcoma is an infection of the blood vessels. All sorts of fungal infections, particularly certain types of fungal lung infections. Toxoplasmosis, that's the one that is normally associated with cat feces and is harmless to most people unless you're a fetus or somebody with AIDS. If you are in Africa, another one to throw out there is tuberculosis. And huge list, but all sorts of infections that people aren't normally getting when they have a healthy immune system. All right, so a few other things here I've covered. Another one, so 2 years ago, I had a question on the final exam that asked for a list of, I think it asked for 3 infections caused by Staphylococcus that were not skin infections. And lots of people gave me skin infections anyway. I have skin infections here. It's just worth kind of listing what kind of things staph can do. There's all sorts of skin infections. I didn't talk about all of them that are on this list, but you can see the ones here, boils and folliculitis are kind of similar. Boils just tend to have more pus, but they're both infections of the hair follicles. Impetigo is sort of soft tissue infection. You've got this scalded skin syndrome here, which is kind of hard to say. And in severe cases, things like flesh-eating disease and so on. So skin infections are, like I said, kind of the big one that everyone knows. It can cause pink eye, conjunctivitis, but we don't need to limit it there. Staph is very good at infecting pretty much everywhere. We can have respiratory symptoms such as pneumonia. We can have urinary tract infections. We can have sometimes food poisoning from different strains of Staphylococcus. We can have nervous system infections, meningitis, brain abscesses, and all sorts of other things, and systemic infections. Bacteremia means infection of the blood, and the big one that is an issue is toxic shock syndrome. That's the one that's associated with tampon usage, but you don't have to be using tampons to get toxic shock syndrome. You just have to have a staph blood infection. That's what is the cause of it. And some of these strains have that particular toxin, which I'm trying to remember the name. It's called the TSST A or 1 toxin or something like that, which is basically literally toxic shock Staphylococcus for ST, and then it's 1 or A. I can't remember what it is, but don't need to know the name of the toxin. Just know that there is a toxin involved in this that can cause that particular condition. All right, what else do I have here? Looks like that is the end of what I had for the study questions that I wanted to look at. And so what I want to do now is kind of leave this open to anyone else who has a study question that you want me to look at. I did put these study questions all in one document up on Moodle, so you can have it in a Word document, and I think I actually made a couple of updates of these things. And so like I said, I'll leave this open, and anybody, if there's something you want me to pick on, just now's the time to let me know. So someone says, are you able to go over the measles portion of this question? Describe the causes, symptoms, treatment, prevention of measles. Okay, so I can. I wonder what the best way is to just need to find a blank something. Maybe I can pull up a Word document, or I could just talk about it. But let's let me see. Maybe I'll throw up a Word document here for measles. I guess I got to share that. Okay, hold on a second. All right, measles. All right, so we've got cause is the measles virus. Okay, so don't get that confused with German measles or rubella. That's actually a separate virus. What else do we have? Symptoms. So symptoms, we've got a rash and a fever are kind of the main symptoms. There are other symptoms of measles I'm not as familiar with. Sometimes people get pneumonias and complications from having their immune system knocked out, and it can be spread to the fetus. And I'm not sure what all the symptoms of spreading to the fetus are. I know that sometimes the risk is stillborn or premature birth. I don't know if there's possible birth defects there as well. I'm not entirely sure without looking that up, but rash and fever are kind of the big ones, and that rash is kind of all over the chest and back. Treatment. Treat the symptoms, unfortunately. So you get the person bed rest and fluids and those kind of things. If they have some sort of secondary infection or pneumonia, you're going to be treating that for whatever it is. And prevention, of course, is the vaccine. So that would be the MMR vaccine. Okay, I know we didn't talk a ton about measles. Like I said, it's kind of worth talking about because there's a very good chance in your lifetime you will see an outbreak somewhere, whether it be at your kid's school or in your community or something like that. And it's super infectious and totally preventable by vaccination. Okay, anyone else have any other questions they want to cover? Like I said, pull up those study questions from Moodle, and you can always, now's a good time to look at them. We also have the other two study sessions I have, which are tomorrow and Wednesday. And those ones are going to be a bit less formal, a little bit more, like I said, I'm calling them study hall, where people can come in and ask questions. And I can always pick on some more study questions, but I won't have anything prepared ahead of time other than just, okay, what do you want to talk about? Okay, let's do this. Or I can always just keep talking about this stuff for a while. Topic 13.1, in order for a pathogen to cause disease, what 3 things must happen? So that's a good one. And that's just kind of actually relating back to the previous topic. So why don't I actually pull up, there's a slide I want to pull up for that. So just give me a second on that. Pull up a slide for that question. Okay, there it is. Okay, it's here somewhere. 1 second. Okay, so share. So that question there is kind of just referring back to this. Technically, there are more than 3 things that can allow an organism to cause disease, but it's kind of just referring back to these mechanisms of pathogenicity. So in order to cause disease, they have to enter the body, they have to enter in high enough numbers, they have to bind, they have to evade the immune response, those kind of things. So it's kind of just hey, topic 13, we're talking about the immune system, and what are some things that can get that organism in a causing disease. So it was just kind of more or less a callback to the previous topic. All right, just looking at the comments here. Yeah, okay, so I think I answered that. New message here. All right, thank you. All right, no problem. Any other questions? Keep them coming. I'll go back to the review slides and I'll put them back up on the screen for anyone to look at. So there's topic 11, there's topic 12. If there's anything there that's screaming out to you, say, hey, let's take a look at. Topic 13, part 1. I know I didn't pick out any questions from this. The big part was the skin, inflammatory responses. Number 8, chapter 12. Okay, let's just go back to number 12 here. Number 8. All right, so endotoxins, that should say exotoxins. So put an X there. Exotoxins, messing up my slides here. Endotoxins, and enterotoxins. All right, so let's see if I can squeeze this on this slide here. So endotoxins. Endotoxins are usually referring to LPS, which is the lipopolysaccharide of the gram-negative outer membrane. So this is usually the cause of septic shock. So septic shock is similar to toxic shock in that you're looking at the immune system kind of having this elevated response to something that is foreign and found in the blood, and fever, low blood pressure, sometimes in severe cases, organ failure, kidney failure, and things like that can be the extreme issues. And that's usually caused because of a blood infection of a gram-negative, and when the organism dies, you've got the release of these endotoxins. Exotoxins, maybe I'll just mention enterotoxins. So entero means gut. And so you're looking at any toxin that causes diarrhea. So classic one here is the cholera toxin. An exotoxin is anything that's secreted by often gram-positives, but not always the case. So I already reviewed a few exotoxins there. We looked at the cholera toxin is also an exotoxin because it's secreted. Enterotoxin just means it's causing that particular symptom, so diarrhea, vomiting kind of thing. Exotoxins, we had the tetanus toxin, botulism toxin, and there's also the toxin by staphylococcus that causes toxic shock syndrome, and so on. All right, someone's asking about the inflammatory response. So maybe I'll pull up that PowerPoint, and worth it taking a look at that. There's a bit more to that response than we did talk about in class. Like I said, the problem with the immune system is how complex things can get, but there is a good summary slide here, and I'll just pull that up here in a second. Just got to find the slide. I think this is the slide I'm thinking of. And there. So this is kind of the slide I'm thinking of here. And so a few things to know. If you take a look at this slide. First, the inflammatory response is usually due to some sort of tissue damage, right? And that damage could be from a scratch or an insect bite or whatever, right? And so kind of the one thing to know is this here part here is that we've got a release of histamines due to the tissue damage, right? So that's kind of part one. Part two is what do the histamines do, right? So the histamines do a few things. They make the capillaries more leaky, and they what's the word I'm thinking of? They open up the capillaries as well and bring in more blood, and that also, and they also recruit things like phagocytes and blood clotting factors and things like that. And so that's leading to the symptoms, right? So the symptoms of inflammation are sharp, right? So sharp is swelling, heat, I'm blanking on the A. Maybe there is no A. R is redness. P is pain or pus. So maybe the A wasn't in there. And yeah, so that's just from the histamines kind of doing their activity, which is doing all those things, opening the capillaries, bringing in extra blood and phagocytes and blood clotting factors and all that. And then everything else is just, that's the consequence of this, right? So the phagocytes kind of doing their job. Hopefully the blood clots and the extra nutrients do some healing and those kind of things. So that's really a very quick overview of inflammation. And I guess the other thing to know about inflammation is that it can be local, right? It can be a tiny part of your body, a scratch or an insect bite, or it can be much bigger than that. So when people have an anaphylactic shock, for example, you're talking about something that's happening in a lot of parts of the body and it affects their breathing and whatnot. It can be fatal. Sometimes inflammation leads to collateral damage in the case of like rheumatoid arthritis and things like that. Symptom versus sign versus syndrome. Okay, that one's in the notes somewhere. And honestly, I can never remember which is symptom, which is sign. I think a symptom is what the patient describes. So I have a headache. Sign is something that someone in the clinic can measure, like a fever. You can measure someone's temperature, you can observe a rash, but you can't, there's no way for us to measure somebody's headache. So the symptom is what only a patient can describe. Syndrome is the combination of both. So it's just some definitions there, right? Somebody's asking about the different antibodies and the different functions. So there are a bunch of different types of antibodies. So IgM, IgG, IgA, those kind of things. You do not need to know the different functions and the different types. I will not be asking you about that. That was one slide just to show you that there are different types and they do have different roles. For example, some of them can cross the placenta or the breast milk. Some of them are involved in kind of the initial response, some of them the later response. IgD, I don't think we even know what that one does. But it's not worth, for this class anyway, knowing all the details there. So don't worry about that. All right, so back to the review questions here. I think we left off here, number 13. And I'll just flip through these a few times if there's no questions. But like I said, you can have me till 12. So today, and I'll be glad to answer any questions. Or you can always toss me an email as well, not a problem. And I'm trying to be as responsive as possible here during the exam period. So adaptive immune response, immune disorders. Topic 14. We'll leave that one up there for a minute. So I think that was actually the last of my questions there. This is my last slide. I just love Calvin Hobbes, so I thought I'd throw this one back up. I think I showed this one to you already. If only things were so simple, eh? So I'll be on the line for another minute or two if there's no other questions. Oh, there's somebody there who's asking about phagocytosis and non-phagocytic killing. So maybe what I will do is pull up that slide as well here. Hold on a second. I think I've got a couple of slides on this one. I just got to find them. All right, just bear with me here. I know I got it here somewhere. Okay, so maybe I will pull up this slide here. Okay, so this is phagocytosis, right? Phagocytosis is the cellular eating, where it's this process. You don't need to know all the steps on this, but kind of just understand what the, I guess, kind of a definition of phagocytosis is. So this is where you have an organism that is, you have some sort of white blood cell that is, folding its membrane, invaginating its membrane, and bringing in some sort of pathogen or something else into basically a food vacuole. So you can see, let's skip ahead here a little bit. There's the food vacuole. Also has a fancy name called a phagosome. So there's that word there, right? It means eating in Greek or Latin. And zome basically means body or organelle or something like that, right? And then usually what happens is you're looking at destruction by fusing with a lysosome. So lysosome, remember, contains digestive enzymes. It's actually a lot like a stomach. It's acidic as well, and that's going to destroy the pathogen or whatever it is. And then it gets released. And sometimes it's released. We've got some molecules that may induce other parts of the immune response. Sometimes dendritic cells actually hold on to a piece of that, and it actually gets embedded into the membrane. That's something called antigen presentation, which is something we kind of just talked about very, very briefly. And there's some more phagocytosis. So non-phagocytotic killing, I also called cytotoxic killing. So hopefully I didn't confuse you there by calling it two different things. And this is, like I said, this is that kiss of death stuff that's going on. And you can see in this diagram here, you're looking at the killer cell is secreting some sort of toxin that's probably punching holes into that target cell. So that's kind of the difference there between those two types of things. Someone's asking, no, I won't ask you about the steps of phagocytosis, but more understand what the process actually is, right? So like I said, kind of think of a good definition, or be able to describe it, or at least recognize what it is if you're asked about it. There's another question here. Someone's asking about tuberculosis being acid fast, and do we need to know the steps for staining and gram staining? No, I'm going to say no on that one. I asked you about that in the last midterm. I don't expect you to know the steps of the staining processes, but it is good to know that tuberculosis is not typically gram stained because it doesn't gram stain. Stains don't bind to it. And I think we're kind of beyond it, worrying about the steps about how to do gram stain. But good question. Okay, just checking the feed here. I don't see any other questions. I'll leave this open and for any other questions, and I'll stay on a few more minutes, even if people still think of some questions. I can stay on the line here for a bit longer. Someone is saying, are we going to see the questions for the past discussions in the multiple choices only? Can you clarify that question? Not sure if I know what you mean by that. Right, so the 25% of the past topics. So like I said before, what I'm doing with the multiple choice kind of section is grabbing a couple of questions from each topic that we've seen in the entire course, right? And so I'm not in the first 10 topics, I'm not looking for all the nitty-gritty stuff like steps of the gram stains and things like that, but some bigger question stuff. For example, we talked about antibiotics, right? So it'd be fair game to ask you about things like selective toxicity or penicillin, things that I would consider, sort of bigger picture stuff that were important concepts in that particular unit. Less likely to ask you about things like the exact mechanism of acyclovir or something like that. And so those will be in the multiple choice sections. And then the rest of the exam, all the written and other parts will be focused on topics 11, 12, 13, and 14. And so that's kind of the exam philosophy I have there. So somebody's asking about what is a super antigen. And so super antigen is usually a toxin. And there's a few out there. And kind of the main one, let me just see if I have the slide hand here. I probably do. So hold on a second here. It's in this PowerPoint here. So I'm going to just skip ahead to that. So that's the slide there that talks about super antigens. So basically, a super antigen is a toxin that doesn't just do damage to the body because of the way of its mechanism, but it's also something that's recognized by the immune system as something foreign. And kind of the number one super antigen is this one here, which is the TSST1, a toxin that's associated with toxic shock syndrome. So that's what's meant by super antigen, right? So you've got a toxin that's not just doing damage to the body, but it's also being recognized by the immune system as something weird. And then you get this, this elevated immune response. All right. Okay, just looking at the feed now. All right, I'm just looking for some more questions, but keep them coming. Just flip through these here. See if there's anything else worth mentioning. So I think I'm looking here at question number 1, this one here, right? And so there's a lot of pathogens, a lot of diseases we've talked about. I know it's it's a huge amount of information. And so what I want you to do with these things is start out here, right? Start out with, what's the organism name? What is it, right? Is it a virus or a bacteria? And what the disease is, right? That's where I want you to start. And then for the rest of the information about these things, I've really selected these organisms for 2 reasons why we're talking about. One is that the organism is important. So it's important because it's either really common, think about things like pneumonia or influenza or staphylococcus. These things are super common infections that we either get all the time or you're going to see in a healthcare setting. So that's one reason why I pick these things. And those things, all these things like MRSA, E. coli, influenza, these are the ones you need to know lots about. You can see they've come up again repeatedly in all of the topics, right? Again and again, we've talked about staphylococcus. So those are the ones you want to know a lot of information in a lot of depth on, okay? The other kind of group of organisms I've selected because usually there's something about them that makes them a good example, right? So for example, African sleeping sickness. I think I've talked about it on a total of 2 or 3 slides all semester. And why do I bring it up? Because it's a good example of a vector-borne disease that's spread by an insect, and it's geographically isolated, right? So it has those two things. It's a vector-borne disease. It's common and very serious in some places in the world, not common in Canada. So that's why I covered it in a ton of depth. But like I said, it's a good example of that kind of thing, right? Malaria, on the other hand, I would expect you to know a little bit more about malaria, which sort of fits that same category in that it's a good example of vector-borne disease, but it afflicts many, many, many more people worldwide. So like I said, start here with each of the organisms, right? Those 3 things: the name, what is it, and what is it known for. And then usually there's some other information about them that's relevant. So things like I just mentioned, mode of transmission or something like that. And then the ones that have come up kind of repeatedly, those are the ones you want to flesh out and kind of have a whole bunch of other notes around. So like I said, I just wanted to kind of clarify that for everybody. And hopefully that helps to focus you with your studying a little bit. Okay, are there any other questions? Like I said, I'm willing to hang out all the way to 12 if you want me to, or even longer if there's lots of questions coming. But that was kind of the plan anyway for today. So maybe I will wrap this up here in a moment. Like I said, there's opportunities for you to come out tomorrow and the following day, and I'll have office hours on Thursday as well for anybody who's looking for, to clarify some things or just kind of get some more hints or tips or whatever. You can always email me as well. So maybe I'll sign it off there, and so best of luck with your studying, and we'll see you when I see you next. So take care and have a great day. Try to get some sleep and some good nutrition in when you study.